Thank you, Dr. Iman. Good afternoon, everyone. So in the next 20 minutes, me and my colleague, Dr. Ahmed Absi, will discuss where are we now and what is the future of first-line therapy of diffuse large B-cell lymphoma. So I'll start with a case. A 68-year-old lady presented with 3 months history of abdominal pain, fevers, night sweat, and weight loss. Past medical history is positive for type 2 diabetes mellitus with peripheral diabetic neuropathy. On examination, she had abdominal distension with a palpable epigastric mass, and her echo performance status is 3. Lab-wise showed a white count of 7, hemoglobin of 10, LDH of 450, normal renal and hepatic functions. CT scan showed lymphadenopathy above and below the diaphragm with bulky retroperitoneal mass and multiple bony lesions. Largest was in the iliac bone. She had also renal and hepatic involvement. Echo was normal. So this is to show you the mass. So biopsy of the mass showed large cells with diffuse growth pattern, with pale cytoplasm and large polymorphic nuclei containing prominent nucleoli. These cells were CD45 positive, CD20 positive, 79A positive, 10 negative, BCL6 negative. Diagnosis was diffuse large B-cell lymphoma NOS. Bone marrow biopsy was positive for lymphoma involvement. So the patient was started on R-CHOP chemotherapy with high-dose methotrexate prophylaxis, and after cycle 2 of R-CHOP, FISH testing showed c-Myc and BCL2 rearrangement. So high-grade B-cell lymphoma with c-Myc and BCL2 rearrangement. According to the most recent NCCN guidelines 2023, patient with advanced stage diffuse large B-cell lymphoma have 2 preferred regimens for their therapy, either 6 cycles of R-CHOP or 6 cycles of pola R-CHOP. Both are category 1 recommendation. The pola R-CHOP, according to the label, is used in patients with an IBI of 2 or more. For the last 3 to 4 decades, CHOP has been the standard of care of therapy of advanced stage diffuse large B-cell lymphoma. A trial published 30 years ago showed that intensification of chemotherapy with different regimens like BCOT-M and MECOP-B did not translate into a better outcomes. However, the addition of rituximab to CHOP, as you have seen today, have improved the outcomes in patients with diffuse large B-cell lymphoma, and currently R-CHOP is a standard of care in the treatment of those patients. In the last 20 years, multiple trials and multiple efforts have been done trying to improve the outcomes in patients with diffuse large B-cell lymphoma. For example, enhancing the anti-CD20 antibody activity with the use of obinutuzumab, and this did not result in improvement in the outcomes. Addition of targeted therapies such as bortezomib and ibrutinib have been tried, especially in ABC subtype diffuse large B-cell lymphoma. And although, for example, in the Phoenix trial, the outcomes were better in younger patients, the trial was negative because the overall outcome or the overall trial did not reach its primary outcome. The intensification of therapy with the CLGB 50303 dose-adjusted R-epoch was not superior to R-CHOP in the long-term follow-up. And maintenance therapy, whether with rituximab or other agent, did not improve the outcomes in diffuse large B-cell lymphoma. However, recently published the POLARIX trial result, you have seen it, the 24 months 24 months outcome shows superiority of pola R-CHOP versus R-CHOP with an absolute difference of 6.5% with a hazard ratio of 0.73. So if your patient has a diffuse large B-cell lymphoma NOS and he or she is PET positive after 2 cycles, do you need to intensify therapy? The answer is no. We had multiple trials showing that intensification of therapy based on interim BIT does not improve the outcome in diffuse large B-cell lymphoma. As an example, in this trial, using a Burkitt-like protocol in patients who were interim BIT positive did not improve the outcomes. What about the CNS relapse risk? The CNS IBI have been used as a prognostic model to assess the risk of CNS disease and CNS relapse. And it's basically used the 5 points of the IBI that we use for diffuse large B-cell lymphoma with the addition of kidney or adrenal involvement. And you have a low risk if you have a score of 0 to 1, intermediate risk 2 to 3, and high risk 4 to 6, or kidney or adrenal gland involvement. So this prognostic model have been validated by 2 different groups, from Canada and from Germany, and it showed that patients with high risk CNS IBI 4 to 6 have more than 10% risk of CNS relapse or progression. The problem, even with the identification, we don't know whether therapy with high-dose methotrexate or intrathecal methotrexate actually prevents the CNS relapse or progression. Multiple retrospective studies recently published, and this meta-analysis I'm showing you here, showing that there is no difference in CNS relapse between CNS prophylaxis and no CNS prophylaxis. What about double-hit lymphoma? Remember our patients after 2 cycles of R-CHOP, we found that she has c-MYC and BCL2 rearrangement. So actually the diffuse large B-cell lymphoma, high-grade B-cell lymphoma with MYC and BCL2 rearrangement, previously called double-hit lymphoma, is a lymphoma with diffuse large B-cell lymphoma morphology and MYC and BCL2 rearrangement. BCL6 rearrangement per se with MYC rearrangement is not considered as a high-grade B-cell lymphoma. It's considered as diffuse large B-cell lymphoma NOS. So to have a double hit, what's called double hit lymphoma, you have to have c-MYC and BCL2 rearrangement. And actually this entity is different than diffuse large B-cell lymphoma. They have worse prognosis, they have higher incidence of CNS relapse and progression, and they are actually, they have lower overall survival. Multiple studies, including this one, showed that escalation of therapy in patients with high-grade B-cell lymphoma with c-MYC and BCL2 rearrangement, for example, using dose-adjusted R-epoch, may improve the outcome with improvement in BFS. However, overall survival in this trial was not improved. So we know that we can improve the BFS, but there is no evidence of overall survival benefit. Thank you all for listening. Now, Dr.